Hi, my name is Osama Ayub. I am one of the registrars in clinical neurophysiology in Queen Elizabeth University Hospital in Glasgow. And in this recording, we will talk about the basics of needle EMG. Needle EMG, you insert a needle inside the muscle, and the needle will record the electrical activity from the surrounding muscle fibers. And these will be presented on the screen, on the machine, and we want to analyze these waveforms to understand where are these generated from and what useful information could be derived from these waveforms to help us diagnose neurological problems. And the way to analyze these waveforms, we look at three things mainly. We look at the morphology, what do these waveforms look like, and the stability and the firing characteristics. And we will talk about these in more details. We will start with the morphology. And if you remember from the anatomy, you have the anterior horn cell and its axon that's attached to many muscle fibers. And every anterior horn cell is attached to many muscle fibers, and together they form the motor unit. So a motor unit is anterior horn cell and axon and the attached muscle fibers. If the needle is recording the electrical activity from the whole of the motor unit, it's called motor unit action potential. And if what we are recording is generated from a single muscle fiber, then it will be called muscle fiber action potential. And the first thing to do to analyze the morphology is to differentiate between muscle fiber action potentials and motor unit action potentials. And the way to do this is we look at the amplitude and the duration and the number of phases. For the muscle fiber action potential, because it's generated from a single muscle fiber, you expect it to be small in amplitude and short in duration usually. It could have the shape of a brief spike or a positive wave. A brief spike like the shape B and C, these are brief spikes. It could be biphasic or triphasic. And these are usually small in amplitude and short in duration. And it could also take the shape of a positive wave like the shape in D, which is an initial positive deflection followed by long negative wave. And the other type is a motor unit action potential. And you can expect, because it's recording from the whole of the motor unit, which contains many muscle fibers, so it's expected to be larger in amplitude and longer in duration with more phases. A normal motor unit action potential will have 2 to 4 phases. And basically, the number of phases is a measure of synchrony between action potentials from different muscle fibers. If hypothetically, if you have a motor unit that all the muscle fibers fire at the same time, exactly at the same time, then the number of phases should be very similar to muscle fiber action potential. But because they don't fire exactly at the same time, you expect some variation in synchrony. So that's why you have phases in the motor unit action potential. But if the phases, the number of phases is more than 4, then you can think about some abnormalities of the motor unit, because there is some degree of more asynchrony. The duration of the motor unit action potential is longer than the muscle fiber action potential, and it's between 5 to 15. And the duration reflects the number of muscle fibers in the motor unit. The more muscle fibers the motor unit contains, the longer the duration. And the amplitude of the motor unit action potential, it can be affected by the position of the needle. If the needle is close to the muscle fibers, the needle will record motor unit action potential that's high in amplitude and sharp. But if the needle is away from the muscle fibers, then the amplitude will be smaller. So it's not, the amplitude itself is not a very good measure of the size of the motor unit. The second thing we look at for analyzing the waveforms is the stability. And basically, you look to see whether the waveforms that you are seeing are similar to each other or they are different from each other. For example, with myotonic discharge that you can see in myotonia, the muscle fibers' action potentials wax and wane in their amplitude and frequency. And in other neurological conditions like neuromuscular junction disorders and sometimes with denervation, the motor unit action potentials show some variability in the amplitude and number of phases because of some blocking to some of the muscle fibers. So you will see some variation in their morphology, and this is stability. So if you see this, we will call this unstable motor unit. And you can see the first one, the upper one is myotonic discharge from muscle fibers, and you can see there are variations in their shape. And the bottom one are motor units, and you can see the initial part of the motor unit are similar, but you can see the last part, the last negative wave sometimes is missing from some of these motor units because they are blocked, and this could be seen in neuromuscular junction problems where some of the muscle fibers are blocked and not conducted. So this is called unstable motor unit. The third thing we look at is firing characteristic, and we look at the regularity of the waveforms, whether they are regular or irregular. Fibrillations and positive sharp waves are fairly regular. So if you look at the bottom shape, you can draw a line that connects the waveforms because they are regular. And some waveforms are perfectly regular, like complex repetitive discharges, and we will talk about these later. And some waveforms are irregular, like end-plate spikes. And we also look at the firing rate. Some waveforms are very slow, like fasciculations, and some are very fast. The process of needle EMG testing involves 3 steps. First, we insert the needle, and the act of inserting the needle itself will generate some activity that's called insertional activity. So insertional activity is caused directly because of the needle insertion. And then we ask the patient to relax the muscle completely, and during this phase we are looking for spontaneous activity, any activity from muscle fibers or the motor unit that's spontaneous with no voluntary control whatsoever. And last, we ask the patient to activate the muscle, to contract the muscle, and during this phase we are looking at motor units, the shape, the morphology of the motor units, and the firing characteristic and recruitment and certain other characteristics of the motor unit. We will start with the insertional activity, and like we said, the act of inserting itself will trigger some activity, and this is normal. But if this insertional activity lasted longer than 300 milliseconds, this indicates increased insertional activity, and this is abnormal. And then we look at spontaneous activity. There are certain spontaneous activities that are normal and could be expected. The first one is end-plate noise or miniature end-plate potentials, and these are small in amplitude, monophasic negative potentials that are irregular. These are the upper shape, and you can see they are irregular and small in amplitude, and usually you see this if the needle is very close to the end plate. And the other waveforms that could be seen and normal spontaneous activity are end plate spikes, and these result from direct needle irritation of the terminal nerve twig. They are irregular and they are biphasic with initial negative deflection, and these are the bottom shape. why do we get this end-plate spike? If you imagine the needle, and the needle is recording spontaneous activity that's originating from somewhere away from the needle. So if you look at the shape on the right, the initial phase when the action potential is moving towards the needle will record positive wave because the electricity is moving towards the needle, so you will get a positive deflection. And then the action potential will continue and moves away from the needle, and then the needle will record negative deflection. So you will get triphasic wave. But if the needle itself is generating the action potential, meaning that the action potential is generated because of direct irritation from the needle itself, then the action potential will move away from the needle and there will be no initial positive phase. You will get initial negative phase and you will get a biphasic wave. And this is what an end-plate spike looks like. If you look at these shapes, you can see it starts with a negative phase. There is no positive initial phase. And this is one of the things that can differentiate end-plate spikes from fibrillations that we will talk about later. So spontaneous activity that's abnormal. These are fibrillations potentials, positive sharp waves. So fibrillation potentials are muscle fiber action potentials. So they have the morphology of a muscle fiber action potential, meaning they are small in amplitude and they are short in duration. They have initial positive deflection because they are generated away from the needle and arrive towards the needle like we explained before. So you will get an initial positive deflection followed by negative deflection. They are usually regular, and this is another difference between fibrillation potentials and end-plate spikes, which are irregular. Fibrillations are seen in neuropathic disorders, and they indicate denervation. They occur when the muscle fibers are not attached to their nerve endings, and they become irritable and they generate spontaneous action potentials. They could also be seen in some inflammatory myopathies, but usually they are seen in denervation. Another thing is called positive sharp waves, and they have the same clinical significance of fibrillations. If you see positive sharp waves, they have the same significance. They indicate denervation. And they are muscle fiber action potentials, so they are small in amplitude, but they are different, that the initial part is positive deflection followed by long negative wave. We don't fully understand why it has this shape, but again it has the same significance of fibrillation, and their firing pattern is regular as well. So these are fibrillation potentials, and you can see they are regular and they have negative initial positive deflection followed by negative deflection. And these are positive sharp waves. They have positive deflection followed by a bit of long negative phase. Myotonic discharges are also muscle fiber action potentials that fire spontaneously, and they are seen in neurological disorders with myotonia, like myotonic dystrophy, myotonia congenita, and paramyotonia congenita. And they are spontaneous discharges, and they are waxing and waning of both amplitude and frequency. And the firing rate could be very fast. And on the needle EMG, on the EMG machine, they have characteristic sound. Complex repetitive discharges are also seen in certain neuropathic, chronic neuropathic, and some myopathic disorders. They're not very specific, They result from depolarization of a single muscle fiber followed by direct spread to the adjacent denervated fibers. They are individual spikes that fire consecutively and limit time linked together, and they could be very high frequency, and they are repetitive, and they have abrupt onset and termination. So these are the complex repetitive discharges. So they have a complex morphology, and they are very repetitive and could be very fast. Fasciculations is another spontaneous activity, but it differs from the previous ones in that these are motor unit action potential morphology. So they are generated from anterior horn cell, and the whole of the of the muscle fibers attached to anterior horn cell. So they are larger in amplitude, longer in duration. They are usually very slow. It could be 1 to 2 hertz, and they are irregular. And that's one way to differentiate them from the regular firing voluntary motor unit action potentials, which are regular and faster than fasciculations. Myokimic discharges are not very common. They are rhythmic, grouped, spontaneous, repetitive discharges of motor units. So they are different from complex repetitive discharges. These are motor unit action potentials that are grouped and repetitive. And they could have high firing frequency as well. In certain cases, they can help you reach a specific diagnosis in certain situations, like radiation-induced nerve damage, but these are not seen very frequently. This is what myokimic discharges look like. We talked about insertional activity, where you insert a needle and see the generated activity, and we talked about spontaneous activity, where you ask the patient to relax and see the spontaneous activity from muscle fibers and motor units. And now we will talk about recruitment. Motor unit action potentials fire in semi-rhythmic pattern. So when you ask the patient to contract, to activate the muscle, it will start with single motor unit starting firing, and then when you ask the patient to increase the force, the activation of the muscle, the frequency of this motor unit firing will increase, and when it reaches certain frequency, usually 10 hertz, you expect recruitment of another motor unit, and then when this other motor unit will increase in frequency, you expect a third motor unit, and so on. The ratio of firing frequency to the number of different motor unit action potentials is approximately 5 to 1. So when the firing rate, with increasing firing rate of motor units, you expect more motor units to be recruited. And this is what we call by recruitment. Reduced recruitment will be seen in neuropathic disorders, because in neuropathic conditions, the motor units are lost for any reason, so the number of motor units decreases. So the ability to add more motor units, to recruit more motor units, will be decreased. So you will see decreased recruitment. In contrast, in certain diseases, certain myopathic diseases like myopathy, myocytes, and so on, you will see early recruitment. And this happened because although the number of motor units remains normal, but the number of functional muscle fibers attached or involved in the motor unit is decreased. So the ability of the motor unit to generate force is decreased. So the number of motor units needed to generate certain force will increase. So when you ask the patient to activate the muscle, with a slight contraction, you will see larger number of motor units firing, so larger than expected for the degree of force, because the muscle fibers functioning as they should have. So you will get more motor units generating slight force, and this is called early recruitment. So this describes recruitment. As you can see, there are 3 different motor units, different shapes. Some motor unit number 1 is repeated, and motor unit number 2 is also repeated. Activation is a different thing, and it refers to the ability to increase the firing rate. So it's different from recruitment. It's the ability of the patient to increase firing rate of the motor unit. Instead of, say, firing at frequency of 5 hertz, the ability to increase this to 10, 15, and 20 hertz. And poor activation may be seen in diseases of the CNS, or maybe manifestation of pain, poor cooperation, or functional disorder. And during our assessment, we need to differentiate between poor activation and reduced recruitment. So this is an example of reduced recruitment versus poor activation. So the above shape, it shows motor units that are firing at frequency of 30 hertz. And you can see all of these motor units look the same. So you are actually looking at one motor unit firing with high frequency. And like we said, the ratio for the recruitment should be about 5 to 1. So if one motor unit is firing at frequency of 30 hertz, you definitely expect other motor units to fire. But here you can only see one motor unit firing. So this means the number of available motor units is reduced. So this is reduced recruitment, because you are not recruiting enough motor units. It's just one motor unit firing very fast. And the bottom one, you can see it's a motor unit firing at frequency of about 5 hertz. And the patient is unable to increase the firing frequency. So the patient is asked to increase the force, but the patient is not actually increasing the force. So this is not poor recruitment, this is poor activation of motor units. Now we will look at the pattern of motor unit abnormalities that could be seen in needle EMG, putting things together. We will start with acute axonal injury. And when there is acute axonal injury, you expect Eulerian degeneration to occur within the first 3 to 5 days. So there isn't enough time for the motor unit action potential to change with morphology. There isn't enough time. So the only thing that you would see is decreased recruitment, because the action potentials are not arriving to the muscle fibers. But the shape, the morphology of the motor unit will remain the same, because nothing much has happened. And this pattern is very similar to pure demyelinating lesions. It's the same concept. The action potentials are not arriving to the motor fibers, to the muscle fibers, so the recruitment decreases. The number of motor units is decreased. The other pattern is chronic axonal loss, and this happens when re-innervation takes place, and usually it happens after weeks to months. The number of muscle fibers in the motor unit will increase, because if you look at the shape, you can see the normal anterior horn cell attached to, say, 10 muscle fibers, but after acute axonal loss and then re-innervation, denervation followed by re-innervation, the anterior horn cell will be connected to more muscle fibers to compensate for the loss of anterior horn cells. So a single anterior horn cell will be attached to larger number of muscle fibers, and the recorded motor unit action potential from this motor unit will be larger in amplitude and polyphasic and longer in duration, because it has more muscle fibers. And this is a pattern that you would see in chronic axonal loss. And the recruitment will be decreased because the effective number of motor units has decreased. Again, if you compare here between the normal and the chronic axonal loss and the acute axonal loss or demyelination, you can see the difference. So with the normal pattern, you can see there are different motor units with different shapes, so different motor unit action potentials. And with the neurogenic, with a chronic axonal loss, you can see it's only one motor unit firing fast, and this motor unit is higher in amplitude with more phases and longer in duration. And when you compare this with the bottom one, with the demyelination or acute axonal loss, you can see the morphology of the motor unit is still normal, but the recruitment is reduced because they are firing faster, but the number of motor units is decreased. The demyelinating is very similar to the axonal loss. You will see normal motor unit action potential morphology with reduced recruitment. With myopathic conditions, what happens is the number of motor units remains the same, but the muscle fibers within the motor unit will decrease. So the recorded motor unit action potential will be smaller in amplitude and shorter in duration. And it could be polyphasic because there is less synchrony between the muscle fibers because of the myopathy. And this pattern is seen with myopathy. And the recruitment itself will remain normal. But what you can see is early recruitment because the motor unit is weaker than the normal motor unit. So you will need more motor units to generate the same force that a normal motor unit would generate. So the patient will recruit more motor units to generate only a slight degree of force. The pattern that we could see in neuromuscular junction disorder, we can see intermittent blocking of some muscle fibers within the motor unit because of the neuromuscular junction problem. So some muscle fibers will not, some of the action potentials will not be transmitted to the muscle fibers. So the shape of the motor unit, the morphology of the motor unit will change between different motor units. And this is what we explained earlier. You can see it's the same motor unit because the initial part is very similar, but the last part, the last negative deflection sometimes disappears because of blocking. In some central nervous system disorders, you can see reduced activation rather than reduced recruitment because the patient is not willing to increase the force because of either functional patients or because of pain or something else. But the recruitment remains the same because the number of motor units is the same, but the firing rate is not increasing. And again, this is the difference between reduced recruitment versus reduced activation. That's all. Thank you.